The cephalosporins are beta-lactam antibiotics and probably one of the most prescribed ones in clinical practice. They evolved because of the presence of resistance to prevailing penicillin at that point of time and have been divided into various generations depending upon the evolution and the spectrum of activity. They are stable against some of the penicillinases or beta-lactamases, and that is how they evolved. From penicillin, we derive the semisynthetic penicillins called the aminopenicillins. Amoxicillin and ampicillin are classical examples of them. These were also the first oral penicillins to be marketed. But the problem was the emergence of the beta-lactamases which could destroy them, including the aminopenicillins. And it was actually gram-positive Staphylococcus aureus which elaborated beta-lactamases which could hydrolyze some of these penicillins. And the first generation cephalosporin actually came for a better cover of the gram-positive bacteria. The striking antibiotics in this group are cefadroxil, cefaclor and cefalexin. Cefaclor in fact has been the most prescribed antibiotic for surgical prophylaxis because of its excellent cover of Staphylococcus aureus, including those which elaborate beta-lactamases. And we could consider the first generation cephalosporins as one which had excellent gram-positive coverage and limited gram-negative cover against susceptible E. coli, Klebsiella and some Proteus species. Then came the second generation with more gram-negative coverage, including Haemophilus and Moraxella, and that's why they were favored for respiratory tract infections. Cefuroxime is the classical examples, and this is the only cephalosporin group which has anaerobic cover, which are the cepamycins. Cefoxitin and cefoxitan are the two antibiotics in these cepamycins which have anaerobic coverage, but personally I have not used any one of them. And then came the most versatile third generation, which had extensive gram-negative cover. If you look, they were now covering Neisseria. In fact, a single shot ceftriaxone is a drug of choice for Neisseria gonorrhoeae, and Neisseria meningitidis, ceftriaxone IV is a drug of choice. Enterobacter, Citrobacter, Proteus, Serratia, and then we had anti-pseudomonal cephalosporin was ceftazidime. So till now, the cephalosporin did not have appreciable cover against Pseudomonas, but now we had ceftazidime with us. But the problem started here with the emergence of new beta-lactamases, which were now called ESBL, which stands for extended spectrum beta-lactamases. And you could define them as a property of gram-negative bacteria which could hydrolyze third generation cephalosporins and the monobacterium Aztreonam. So if the beta-lactamase could hydrolyze a third generation cephalosporin Aztreonam, it came to be known as ESBL, and that is where we had the beta-lactamase inhibitors evolved to protect some of these antibiotics. And then came the new generation of beta-lactam inhibitors like avibactam, which now is available with ceftazidime, which is a cephalosporin, and it has been able to cover ESBLs and also some of the carbopanases. Example are KPC from group A and OXA48 from group D. Then came the fourth generation cephalosporin, cefepime. It is stable against some of the beta-lactamases like AMPC, so it just gives you a little edge, and it also has anti-pseudomonal cover. The third and the fourth generation cephalosporins have excellent CNS penetration. That is why you will see whenever Pseudomonas is involved, we choose cefepime or ceftazidime, and when we have community acquired meningitis, then ceftriaxone is the drug of choice. One important property of ceftriaxone is its long half-life, which is in contrast to other cephalosporins, and hepatobiliary clearance. So it does not require dose modification in renal failure, and it can be given as a once daily dose as well. Then came another breakthrough, which was in terms of the fifth generation cephalosporin, ceftaroline, which is actually available, and it has anti-MRSA activity. We can just review what this MRSA phenomena is. We have known till now that Staphylococcus aureus develops resistance by elaboration of beta-lactamases, but unlike the gram-negative bacteria, this hydrolyzes limited number of antibiotics. But if the Staphylococcus develops penicillin binding protein changes, which is the site at which all the beta-lactam antibiotics attach to the cell wall, they become resistant to the beta-lactam antibiotics because the site of contact for these antibiotics is now altered and they are not able to attach to the cell wall. Methicillin is stable to the beta-lactamases, but if there are changes in the PBP, then Staphylococcus becomes resistant, and thus MRSA means abnormalities in the penicillin binding proteins. This has now been overcome by structural changes in cephalosporin. Ceftaroline is a classical example. It is able to act against methicillin resistant Staphylococcus aureus because it has a different binding site. Ceftaroline has no antipseudomonal activity unlike its third and fourth generation counterpart cefepime and ceftazidime, and it is susceptible to hydrolysis by ESBL. So it has gram-negative cover but not against ESBL organisms. It has activity against Haemophilus, Moraxella, and remarkably against streptococci, including the ones which are ceftriaxone resistant, and that is why it is one antibiotic which can be used in community acquired pneumonia. And since it is cell wall active antibiotic, it will have no atypical coverage and you can add an atypical to it. And now we have the newest cephalosporin, which is cefiderocol, also called 6th generation. It has unique siderophore activity, which basically means it uses the ion channels which the bacteria need. The bacteria needs iron for its metabolism, and there are channels for its transport, and cefiderocol uses those channels. So what happens is they are protected against many of the beta-lactamases, because we need to understand the beta-lactamases act on the extracellular area, and if an antibiotic can somehow enter and rest itself in the cell wall, then it is protected against the beta-lactamases. Cefiderocol has activity against many beta-lactamases, including metallobeta-lactamases, against which all the cephalosporins are inactive. It also has activity against Acinetobacter, which is not seen with other cephalosporins, including the one which is carbapenem resistant, which is called carbapenem resistant Acinetobacter baumannii. And it has been tried against colistin as a comparator and has been shown to have better outcomes. It also has anti-pseudomonal activity. In general, about cephalosporins, they have limited anaerobic activity. So whenever anaerobic cover is desired with them, we need to add an antibiotic with anaerobic cover. So when ceftazidime avibactam was used for intra-abdominal infection, it was used along with metronidazole. They have no appreciable enterococcal activity. Contrast this with ampicillin, which is actually the drug of choice for drug-susceptible enterococci. It has limited Acinetobacter activity, all cephalosporins except cefiderocol, and they are susceptible to ESBLs except against cefiderocol, which is active against many beta-lactamases. Even novel beta-lactamases don't act against the MBL. So even if you add avibactam to a cephalosporin like with ceftazidime, it will not cover metallobeta-lactamases. Select agents have anti-pseudomonal activity, as we have already elaborated, cefepime, ceftazidime and cefiderocol. And one of the major concerns with cephalosporin use, especially the third generation cephalosporin, is units where they are used more extensively, there is greater emergence of ESBL strains. So there is a selection bias for maybe ESBL strains to emerge when a third generation cephalosporin is used. And that is why in many clinical situations, as part of the stewardship program in the hospital, we look for an alternative agent to third generation cephalosporin to decrease the incidence of ESBLs. A comparable drug is amoxiclav, which is protected against many of the beta-lactamases because of the clovulinate, has a spectrum of activity which is comparable to the third generation cephalosporins, and there is an increasing interest in the use of the aminopenicillins with beta-lactamase inhibitors to stop the emergence of ESBLs. So cephalosporins have been in use for a long period of time. They are evolving, the spectrum of activity is changing, and we expect more agents to be added to to this group of antibiotics.